Ulnar impaction is a condition characterized by contact of the ulna with the carpus. And it's most commonly associated with ulnar positive variants, as you see here, but it can occur in ulna neutral or ulna minus variants, particularly with loading with the forearm pronated. It results in many cases, erosion or tear of the TFCC articular disc. There may be a kissing lesion, as you see here in the lunate. Signal changes on the MRI correspond to that. There may be a non-dissociative lunotriquetral tear, very, very rarely a VC deformity consistent of a LT dissociation. And there are a wide variety of causes, from congenital or developmental changes in ulnar length to post-radius fracture shortening and deformity, growth arrests like Madelung's or post-physeal arrest in fractures, radial head fractures after resection. So there are a whole host of issues. And of course, we know that in the general population, there's a range of ulnar variants, as Hull 10 described 100 years ago. Ulnar impaction etiology is varied, and in distal radius fractures in particular, treatment depends upon radius alignment. If the radius is short but not altered in terms of slope and radial inclination, a ulnar shortening or another ulnar procedure may be satisfactory. Otherwise, a radius osteotomy would be the first recommendation. If it's pure ulnar impaction, you basically have two common options: shortening or wafer resection. Wafer resections can be done open if there is no TFCC tear in particular, and in most cases where there's a central disc tear, you can do it arthroscopically. Ulnar shortening is kind of the gold standard. It was described by Milch back in 1941. These are photos from his article of a case report. He said that it healed in 2 weeks after this firm cerclage wiring. So he's a better surgeon than the rest of us are, I think. Ron Linscheid and basically the whole Mayo group back in '85 described a shortening procedure using plate and screw fixation that sort of advanced the Milch procedure to more modern fixation. And they used it for a variety of treatments, including impingement, for which it has become the gold standard. Ulnar shortening has several advantages. It doesn't disrupt distal articular structures. Any desired length of the ulna may be resected, including very large differences. And it does seem to tighten to some degree the ulnocarpal ligament complex, which may improve instability at times. But it does require a big scar with a big dissection and lengthy healing times, mean healing times of 3 months, and union taking more than 4 months or not healing at all are not uncommon. Painful hardware frequently requires plate removal or a second procedure, and delayed union or non-union may occur in as many as 20% of patients in some reports. Distal radial ulnar joint pain or dysfunction may be possible due to excessive shortening or sigmoid notch morphology, and also potentially causing arthritis. And in particular, this type C variant, in which the styloid or the sigmoid notch is oriented facing distally, potentially may cause abnormal contact forces with shortening of the ulna. And this is a risk that may be better avoided with a wafer resection. And distal radial ulnar joint arthritis may occur also in shortening very large distances, or when the healing time is prolonged. Again, non-union rates may be high. Smoking definitely is a risk factor in this study from Germany. And in smokers, 7.1 months of healing time, I think, is probably unacceptably long. However, this study by Owens was a systematic review of ulnar shortening, looking more or less specifically at healing, and found that the non-union rate was actually reasonably low in this large series of 1,400 patients. And interestingly, it didn't make any difference, significant, at least statistically, whether it was a transverse or an oblique osteotomy. They had no particular information on time to union or need for plate removal. Wafer resection is the less popular option. It was described by Felden and by Renowrowski, both in 1992, one as an open procedure, one as an arthroscopic procedure. And the arthroscopic wafer today is widely practiced. It's indicated when the ulnar plus variant is less than or equal to 4 millimeters, in the opinion of most people. Ulnar shortening osteotomy should be used otherwise. And wafer resection tends to work best when TFCC tear is present. It's minimally invasive. There's no risk of non-union, no hardware issues, and it allows an arthroscopic assessment of the joint, early motion, no casting. And so that's the real advantage. The potential problems may be excessive resection, may lead to excessive loss of joint cartilage surfaces, and therefore should not be done in large defects. And you don't get the secondary benefits of realigning areas of chondromalacia or increasing tension on ulnar stabilizers. And the technique is basically fairly simple. You have a look in the joint, you visualize the tear, you debride a little bit of the articular disc, and then you put a shaver in the joint in order to clean it up. I'm going to skip the video, but basically what you do is you burr down below the cartilage and subchondral bone, typically over about 2/3 of the ulnar head. And here you see what it looks like before and after. The results of wafer resection have been really very good in these two series. The largest percentage of patients had a good result. Which operations should be done? Well, the papers that compare results between authors basically show results of arthroscopic wafer resection in terms of satisfaction to be, if anything, better than ulnar shortening. And objective parameters of outcome also tend to be equal or better than ulnar shortening. This study by O of 42 patients demonstrated with improvement over time, found that at 3 months, the wafer procedures were consistently better. And after 3 months, clinical results were similar, but the complication rates were very much higher, including arthritis, painful hardware, delayed non-union, and refracture after plate removal with shortening that were simply not seen in wafer procedures. And another study by Bernstein with similar results, wafer similar results with fewer complications. A study by Constantine also with 9 of 11 wafers with excellent 8 of 11 ulnar shortenings, but only 1 additional resection in the wafer procedure and 5 operations to remove painful hardware in the shortening, as well as 2 delayed unions. So in the end, I prefer wafer resection in most circumstances. The comparative literature supports this point of view. Ulnar shortening is only preferred in my practice when there's a large ulnar positive variance requiring a larger amount of adjustment of length. And neither should be performed alone in the face of a malunion of the radius with altered radial alignment or in cardiogenic arthritis and instability. Thanks.